Good afternoon and a warm welcome to this webinar. And we are MedGenome, the leaders in genetic testing in India, and we are organizing this webinar as part of the Primary Immunodeficiency Awareness Month. And the topic for today's webinar is the role of NGS in the diagnosis of primary immunodeficiency disorders. And our speaker is Dr. Sheetal Sharda, Senior Consultant, Clinical Geneticist at MedGenome Labs. Dr. Sheetal Sharda is a pediatrician and has done her DM in medical genetics from SGPGI Lucknow. She has worked as an associate professor in genetics in PGIML Chandigarh for 8 years. She has over 13 years of experience in clinical genetics. She also has about 30 publications in national and international journals to her credit. Her areas of interest are dysmorphology, prenatal diagnosis, and molecular diagnosis. And before I hand over to Dr. Sheetal, I want to inform the audience that if you have any questions or comments, you can type them out in the Q&A or chat window of the Zoom browser that you're seeing this webinar through. And we will also be sending a recording of this webinar in case you miss out any points or would like to revisit some of these points later on. And you can access it through the link that we sent you, and we'll also put this up on our YouTube channel also. So without any further delay, I will now transfer the host to Dr. Sheetal, who will take this webinar forward. Over to you, Dr. Sheetal.
Thank you, Joseph. Good afternoon, everybody. I welcome you to this webinar. This is a series of webinars for general awareness regarding the molecular genetics in the diagnosis of genetic disorders. Based on this, today I would be focusing on the use of molecular genetics, especially next generation sequencing, in the diagnosis of primary immunodeficiency disorders. So just an introduction to the primary immunodeficiency disorders. Those who deal with it, especially the pediatricians, must be aware that it is not a single disorder that we are talking about. It is a heterogeneous group of disorders, and the basic abnormality is in the immune system, which manifests clinically as increased susceptibility to infection. So this is a group of about more than 130 disorders, and they may affect anywhere between the development of the immune system or the function of the immune system. And if we would like to classify them, then they can be broadly classified into adaptive immunity, and the second group is innate immunity. And further distribution of the PIDs based on these broad classification could again be whether it is a combined cellular and antibody deficiency, just cellular deficiency, phagocytic deficiencies, or complement deficiency. As you can see, majority of the disorders would fall under the group of antibody deficiency. So PIDs would basically be suspected in patients who are having recurrent infections. So it could either be recurrent ear infections, recurrent pneumonias, but along with that, there are other things which are also necessary, like failure to thrive. There would be a poor response to antibiotics, persistent thrush or skin abscesses. Family history is also quite important. And also, if you have a patient who has multiple autoimmune diseases, irrespective of the age, they would fall under a group of primary immunodeficiency. And there is a Jeffrey Model Foundation, which has 10 warning signs of immunodeficiency. Anybody can go through them and understand that there are almost warning signs right from the first infection which a child can have. If it is at an abnormal site or due to an abnormal organism, they could also be into one of the primary immunodeficiency group of disorders. And for diagnostic testing, we have multiple tests available. So initial would just be a CBC or a lymphocyte count. In certain disorders, there would be neutropenia. In other, it would be lymphocytosis, along with thrombocytopenia or anemia also. And for further testing, we may go for higher tests like lymphocyte proliferation assays, flow cytometry. We have to measure the immunoglobulin levels, assessment of serum specific antibodies in response to vaccine antigens is also a good test to know the type of disorder we are looking into. Neutrophil function assays and assay for cytokine responses also form one of the testing methods. Along with that, if you are suspecting complement studies, we have tests for that too. And management wise, usually they are difficult to treat by routine antibiotics, and usually immunoglobulin replacement therapy is the mainstay, especially for B cell disorders. And it is also a supportive treatment for combined immunodeficiency disorders. The innate immunodeficiencies, the treatment would vary depending on the type of the defect, but we may need antibiotics, we may need antifungal, we may need cytokine replacement, and sometimes it may go on for a bone marrow transplantation also. So coming down to the main topic of today, that is genetics of primary immunodeficiency. In the last 10 years, multiple genes responsible for many of the common but the best studied immunodeficiency have been identified, and these expressions are limited to the hematopoietic system. So some immunodeficiencies may involve the effector function, some may involve the signal transduction pathways. And mutations for each disorder tends to be highly variable. Sometimes it may be just a single gene which is responsible, but sometimes polymorphic variations in susceptibility genes also contribute to the disease. For example, a child having recurrent tuberculosis at various sites with a family history or not responding to the routine therapy, anti-cox therapy, may be having a variation in the gene which can cause susceptibility to mycotuberculosis. So along with mutations, we may also have to look for certain polymorphic variations. And unfortunately, not many genes have been identified. There are few immunodeficiency disorders, which in spite of doing all the laboratory tests also cannot fit into a well-described genetic disorder. So we have to know this limitation before we send testing for primary immunodeficiency disorders. So after doing all the basic workup, the lab analysis, the assays, the cytokines, etc., if you can shortlist a disorder or a broad group in which it is falling, the next step would obviously be confirming it by a molecular genetic testing. So molecular testing is basically to analyze the sequence of the DNA to determine the mutation which can explain the disease. So what we are trying to do is having an association between the genotype and the phenotype. So whatever biological network or whatever molecular abnormality which we are getting, whether it will explain the disease in your child is known as a genotype-phenotype correlation. And that is the purpose of doing a molecular genetic testing. And there is no single genetic test. There are multiple tests available, and that is more confusing to already the big list of tests which we have for PIDs. So everybody would be aware of Sanger. Sanger is the traditional or the conventional way of testing for genetic mutations. The thing with Sanger is that we have to know what gene we are testing. We have to know what mutations we are testing. And so this is the limitation, that if it is a very big gene or if there are multiple variations which have been reported in a particular gene, Sanger becomes a little costly as well as time consuming and not enough cost effective also. Unlike the newer tests which are coming up, like next generation sequencing, which can at a time test multiple genes, multiple disorders in one go. The next generation sequencing, which everyone is talking about, is basically a higher definition of initial traditional Sanger sequencing. The methodology may be a little different, the techniques may be different, but the basic principle is still the same. We go for PCR and then we sequence the ATGC variants. So it is a high throughput, massively parallel and rapid technology. Due to this, it is decreasing the price and the time and the error rate of the test which we are doing. And also we are getting increasingly high quantity and quality data, and the repertoire of bioinformatic tools are helping in this. So even in next generation sequencing, we are already gone to the 4th generation of tests, which are definitely much better than the 1st generation of the NGS sequencing which we used to do. And it is definitely a paradigm shift from those old days when it took almost 13 years to decipher the whole genome with 2,000 plus machines and equal number of people who would work on those machines. And the amount of raw data which we would get per day per instrument was nothing compared to what we can do it today. One machine, one person, and you can get as high as 2,500 million bases per day with as low as $50 for 1 GB raw data. So this is definitely a paradigm shift, and everybody is aware how the pricing is going down based on the innovations in the chemistry, the optics, the fluidics, and the computational hardware. All these newer solutions are having an impact on the cost. So when there was a time when it was costing more than $1.5 million for a genome, probably a time would come when we may have to give less than $1,000 for your whole genome. So this is having a high acceptance rate for patients, for doctors to send for genetic testing. And it is definitely a better, I'm sorry, better method than the original or the traditional genotyping method, because along with the common mutations, we can also test for the uncommon mutations, and in and day out, we have come to diagnose novel mutations in various genes and disorders. So when we come to NGS, the basic is that we have a gene. A gene is basically the DNA, which has introns and exons. And when we test for diagnostic purposes, we usually do the exome sequencing, or we are focusing on the coding regions of the genes. And we all know that almost 85% of all disease-causing mutations are positioned within the coding exon. So if we just focus on this 1% of the whole genome, probably we would be finding a good pickup rate for disease-causing mutations. Along with that, we also have targeted testing for smaller panels. So for clinicians, when they say what to send, whether we should send for whole genome, whether we should send for whole exome, so it all depends on what exactly you want to test for. So if you have a very specific diagnosis, if you are sure of your diagnosis based on whatever test you have done, seeing the clinical symptoms and the laboratory test or biopsies or MRI, you know that you are sure of a particular differential diagnosis, then it would be cost effective to do target panels in which limited genes which are related to the disorders are all covered in one go. Beyond that, if you want to go further, we can go for clinical exome, which covers the Mendelium, which means that all the genes which are reported in OMIM, which is online Mendelian inheritance in man, to have a good genotype-phenotype correlation, and that accounts to around 8,000 genes will be covered. But again, this is only the coding regions. And beyond that, which is recommended by all labs, is that going for whole exome, which would cover the coding regions of all the 23,000 genes which have been identified till date. The only thing is that we are covering a larger proportion of genes, and hence the costing would be more, which will go down to the patient, and they may not be ready to give a larger cost for a less number of genes. And beyond that, obviously the best is whole genome, in which the entire genome non-preferentially is covered, including the exons and introns. But for practical purposes, it is still at the research or academic interest only. So which test you want to know or send will depend on amount of information you want from that test. And more data doesn't automatically convert to more knowledge, because if you can see whole genome, whole exome, gene panels, you can see the amount of data. It is in GBs. Like if you get so much of data, how to interpret it becomes important, because from one person, from one genome, when we consider that we are 0.01% variable from each other, a whole genome will throw out around 3.5 million variants. And from those million variants, if to have one or two relevant variants which has a disease implication related to your patient, it becomes important that we have to have a biologically meaningful manner of interpretation and organizing this data, which is shot back to us from the machines. So the workflow seems quite simple. You put in a sample, you do the library preparation, you do the sequencing, and as you can see, what we get out is just colorful dots. Converting those dots into computerized readable data is the work of the bioinformatics people. But beyond that is also some work to convert this information into readable format, which is important to send it across to the patient as a report, again has another pipeline. So NGS is not just a big machine. The data interpretation by the bioinformatic teams becomes a very important part of this workflow. And as you can see here, there are a few steps in simple manner. If we say that there is a lab team which is doing some work, and then there is a bioinformatics team which is converting that data, and then there is a genome analyst team. And how these variants are classified or how these variants are filtered will depend on multiple things which will help us prioritize a variant. So we have to base the variance filtration based on, they should be coding variants. The frequency should be such that it is not very common in the population. It should be, if it is reported in certain databases of significance, then it becomes important. We have to use certain conservation and prediction tools. And then we also have to validate them in your own ethnicity-based population. If we don't have enough literature, sometimes we may also have to do segregation analysis in the family with patients and the control population who don't have the same variant. So a lot of filtration goes into classifying a variant as being significant. So how do we classify this variance? Again, we have strict protocols. We have guidelines by American College of Medical Genetics, which is followed all over the world. And they classify the variants according to their significance. So a variant could be any change in the gene. It could be pathogenic, but it could also be totally benign. So for reporting, we usually focus on those variants which could be pathogenic, likely pathogenic, and there is a big chunk which is falling into a group of variants of uncertain or unknown significance. So as you can see on the slide, pathogenic would definitely be a significant disease-causing variation which can explain the patient's symptoms. So there should be a good genotype-phenotype match. Secondly, the variant should be having such information that the prediction has to be an abnormal or a poor protein. Likely pathogenic is, again, it can contribute to the development of disease, but till date or till the time when we are reporting the variant, the scientific evidence is not sufficient to prove this, that it is a pathogenic variant. So we can classify it as at likely pathogenic. And then almost 30 to 40% of the reporting of an NGS lab is variant of uncertain significance. And this percentage is uniform all over the world. Because this variant which we have detected, we can neither classify it as pathogenic nor we have information to cause it as benign. So based on the current literature, we have to classify them as variant of uncertain significance. The thing is, this variant on a little passage of time could either be converted or reclassified as pathogenic, likely pathogenic based on added literature, or it could also be reclassified as benign. So for this variant of uncertain significance, we have to be very careful, and we have to understand that variant of uncertain significance doesn't mean a normal or a negative report. It just means that it is still at present a work in progress, right? So if anybody wants to read, this is the guidelines. It's a big paper, but yes, for your knowledge, you can go through these guidelines and understand how a lab would report these variants. So I would just be covering the filters one by one. The minor allele frequency is very important because rarer the variant, higher the chance of it becoming pathogenic or likely pathogenic, higher the variant in the population, or what we call as minor allele frequency, higher the chance that it may be a benign, likely benign, or just a polymorphism. But again, we have to take it into mind that certain disorders in certain populations may be quite common, and hence the MAF or the minor allele frequency could be high for certain variants, but we have literature for them, and if they are portrayed as polymorphism causing a pathogenic change, it will be reported. Second is, we should always check for the depth and coverage. So that shows that we have enough data and we are confident regarding the variant which we have got in the analysis. So the depth is the how much percentage times or how much time the genome has been expressed. So, and coverage means how much percentage of the genome was sequenced with a depth of more than 0. So coverage, when you see, it should be between 30 or more, which is a good coverage. I'm sorry, that is the depth, and coverage of the genes is different in every patient. So that is usually given in the appendix, that the coverage of a particular gene is appropriate for that testing. Then there are various public databases in which a variant has been reported. As you can see, there are multiple, and each database has different set of variants which have been reported. And if we combine them also, a very less amount would be there, which is common in all. So sometimes we may have to search multiple databases just to see whether it is a reported or an unreported variant. The next important thing is the conservation and prediction tools. Again, there are multiple, and we may have to, each lab chooses the best ones, and there are certain CAD scores used, and newer prediction tools are coming. They are helping us, but also sometimes confusing. Two of them would be saying damaging, one would say benign, but we take the best ones what for that variant are predicting. And then again, important becomes a visual examination of the variant. So in a chromatogram or a Sanger sequencing, this is a chromatogram you will usually see, which shows whether the variant is homozygous or heterozygous. But in a NGS report, what you would get is a IGV, or integrated genome visualization. And here you can see that the number of reads, if you can see on your screens, the total count is shown as 61. So the depth or the covered area of that particular variant is like it has been counted almost 61 times, and all the 61 counts are showing the same change. So this is a homozygous variant. So this is how an IGV of all the variants will show us whether it is a heterozygous or a homozygous variant. So now when we use these filters, you can see that among the total variants which the bioinformatics team sends us, the next step is what a genome analyst would do. And based on the coverage of the gene, it should be more than 30x, whether it is a significant variant nonsense or a splice site or a stop loss. Again, we filter it furthermore, and it would remove the unnecessary variants which are not falling into this category. And then we have to choose a minor allele frequency. We check the variant in the IGV, and then we, after putting the ACMG classification, after almost 3,000 genes, we ultimately can shortlist almost 20-25 genes, which could be worth reporting or ignoring. So you can see that it's not very easy to even interpret the data which we get. So just a quick way of how you should be interpreting report once it comes to you. So first you have to see whether the gene of interest, what you were wanting, is covered perfectly. So if it is a single gene and you wanted to check for SCN1A, so the report would say that it is 100% covered. Sometimes it may be a poorly covered area. So the lab would also need to tell you that this gene is not well covered. Second, it would show whether it is a heterozygous variation, it is a missense one, which exon it is falling, which chromosome, the depth of that coverage, and then what change it is doing in the protein level. So all this information would be there in the report. Then if it is in a critical domain or a good or a protein domain, that will also be informed in the report. It will be told whether it is reported in any of the genome database. So here this variant has not been reported in the public database. So that means that it is a very, very rare variant, and it is not found in the general population who doesn't have the disorder. And then we use the in silico prediction tools, and it is probably damaging by 1, 2, 3, 4 of the prediction tools. So it becomes significant again. And then the reference codon is conserved. So based on so many evidences, finally the variation would be classified as likely pathogenic. And then again, we have to correlate it with the clinical symptoms also. So this is the final how we find a variant. So coming on to few cases which will help us know how it has helped in primary immunodeficiency disorders. So this was a child who presented with chronic cough, ear infections, pneumonia, URTI, episodes of eczema, and bleeding tendency with thrombocytopenia. And his male sibling also has similar problems. So the differential diagnosis according to the clinician was Wiskott-Ulrich syndrome. And with such a clear diagnosis with a family history The diagnosis, if confirmed by genetics, is definitely good for everybody. Here it is an X-linked recessive disorder, which you can see in the table, and it is hemizygous, means a male who has single X, the zygosity would be hemizygous, and as per classification, it would be a pathogenic variant. So this gives a happy result to the clinician, to the doctor, and even us, because we are happy to help the family with a positive result, which can help the treatment, the management, the prognosis, as well as prenatal diagnosis. Another child, sometimes there is lot of things which are there, and a differential diagnosis may not be a single thing, but multiple. So a child who has global developmental delay, seizures, epilepsy, status epilepticus, and multiple other things, like he had ichthyosis, dermatitis, and there is also history of severe infection with pleocytosis, and brain also is showing abnormality. So the differential diagnosis was acardioguttry, Niemann-Pick, tyrosinosis, or congenital disorder. So multiple differential diagnosis where the clinician is also as confused as we are in what it could be. So what we found was a homozygous variant in an autosomal recessive condition, which is called recurrent infections associated with encephalopathy, hepatic dysfunction, and cardiovascular malformation. So now, as a clinician, we have a small list of disorders which we see over a period of our practice, and it is not always easy to put a diagnosis. And so this is a retrograde diagnosis, that after getting a genotype, you are able to confirm the phenotype also. So in a confusing phenotype, if you get a final diagnosis, which is confirming your clinical features, again, even in spite of being confusing, it is definitely helpful for the patient to get a final diagnosis. The worst thing which can happen to clinicians is when they send a sample for as simple as osteomyelitis, liver abscesses, and IgM levels, and a suspicion of hyper IgM. So we feel that it is such an easy diagnosis and we should get something. But unfortunately, we don't get anything. So this becomes a non-report and nobody is happy with this. So what does a negative report mean? Does it mean the child doesn't have the disorder? No. A negative report means that there could be deletion duplications in the gene which cannot be tested by NGS method. So probably some other method needs to be done to get a diagnosis. There could be trinucleotide repeat expanses, though there are very few disorders, not in PID, but in neurological, which we know that also cannot be picked up by NGS. Similarly, there could be some low covered target region, like promoter regions or deep intronic regions are not covered by NGS, or it could be a copy number variants, again, in a heterozygous form will not be covered by NGS. So technical issues are always there, and sometimes mutations in other genes which are not covered in that panel, not covered in clinical exome, or maybe present only in the whole exome, may be there, which we have not tested in our limited panels. Sometimes it may just be a non-genetic disorder. So when you suspect a primary HLH, it could be a secondary HLH. So you may not get something in that condition. So negative report means you need to work up further. The patient also, maybe some lab testing, maybe we need to wait and watch and reanalyze the data after 6 months or so. And another, which I have described before, variant of uncertain significance, is a big dilemma for everybody. We can't take a decision, we can't ignore it. So this was a child who presented with pure red cell aplasia, pallor, and failure to thrive. And he was suspected to be affected with pancreatic insufficiency. And again, a big list of differential diagnosis. What we could find was a hemizygous variant, again, it being an X-linked recessive condition in a male. It was a sideroblastic anemia with spinocerebellar ataxia. The variation has been previously reported in ClinVar. The variant has a low minor allele frequency, and the in silico prediction was damaging. So it was not matching the phenotype, but being an reported variant and partially matching, we reported it. The clinician was sure that this is not what he was looking for. So now what? So either we go for a reanalysis, we go for further clinical correlation, whether any other test can be done. We need to reevaluate the patient also, and we need to reevaluation what data we have also. And sometimes segregation testing can help in such cases. So again, this patient had gone to another doctor, and a year later, so within a year, the phenotype evolved. Now this patient presented with fat malabsorption, recurrent admissions for pneumonia. And the second clinician gave a differential diagnosis of cystic fibrosis or primary immunodeficiency. So you can see that based on the clinical phenotype, two different clinicians will obviously give different clinical diagnosis to the lab. And here, when it was considered that recurrent admissions for pneumonia and fat malabsorption, we rechecked for primary immunodeficiency disorders, and we could find compound heterozygous variants in cystic fibrosis or the CFTR gene, which was pathogenic, and it can explain the findings in the patient of failure to thrive, anemia, fat malabsorption, as well as recurrent pneumonias. So we can see that over a period of time, probably if we try to reanalyze the data, we might get something of significance which might have missed before. This could also be because initially the clinician was suspecting Diamond-Blackfan, and he sent for just the Diamond-Blackfan anemia gene panel, which has 16 genes. We concentrated on those 16 genes. But when he suspected primary immunodeficiency, the amount of genes, as many as 300 genes, were tested, and that is how we got a better diagnosis. This is another case in which the child was suspect of infantile osteopetrosis. Now, infantile osteopetrosis is a very typical finding, and just an X-ray is the diagnostic test for this, and it should not be missed. But the first time the NGS done, no pathogenic variants were detected in the osteopetrosis gene panel. So we gave them the list of the genes which were tested, but we didn't find any pathogenic variants. Now, on detailed examination, because it was such a typical finding, we did a reanalysis, we did a deeper analysis, and we found that there was a 22 base pair deletion in the intron-exon junction. So this is not a very good area for NGS, but since the diagnosis was so typical, we had to analyze this further down, but also that the depth was very poor. For a 7x depth, the variant would have missed if we use the normal filters, in which we have a cutoff of 30x as a depth. And this, as you can see in the IGV, again, it was a very poor variant, and this could have been easily missed out. Again, before reporting it, we wanted to confirm that it is a true variant, and hence the parents were also tested, and segregation analysis confirmed that the same variant was present in a homozygous state in the child and in the heterozygous state in the parents. So step by step, we have to approach so that we can confirm that yes, this is a significant variant. So a none report or a BUS report sometimes just needs more evaluation. Based on this, you can see that genetic literacy is very important, not only related to genetic itself, but related to the newer tests which are available. It is a challenge that the interpretation and exchange of data is requiring a lot of interaction between the clinician and the lab. So clinician who is involved in the patient care and the patient who is suffering because of this disorder and needs an answer, obviously the connection or the communication between the lab and the clinician is an ongoing process. And to interpret the data also which you are getting is not a routine blood, it is not a routine blood test that if you do a hemogram, you will get a small slip in which all the parameters are written. This is a genetic test. It has its implications, it has its limitations, and there are a lot of things which we still don't know. So genetic literacy by clinicians is important for explaining the limitations of the test. Ethical consideration is a big thing because the benefits and harms of a patient who is not being informed about the test can have a big impact on your practice also. For every city, every state, every country, the guidelines may change. But unfortunately, India, we still don't have any protocols or guidelines for the genetic testing. But I would just request all the clinicians out there that be very clear in what you want to test. Be very clear explaining to the patient, or a pre-test counseling, which we say is very important to make them understand that the pickup rate of tests is 80%, 20%, 50%, because the patients have expectations. They say that if they're spending so much money, they need a result. So a pre-test counseling before sending the test, or a communication with the lab to understand which is the best test for that patient for that particular disorder. If you know that, then definitely the post-test counseling becomes much easier. The explaining the patients the result becomes much easier. Sometimes we may get incidental findings which are unrelated to the disease in question. So do you want to know about it? Does the patient have the power to understand that limitation or the finding of incidental thing on adult onset disorder? That also has to be taken in consideration, and we should have consents for that. So I just want to summarize that definitely the newer tests which are coming up, especially next generation sequencing, is having a dramatic effect, and the pickup rate and the diagnostic rate of rare disorders is definitely going exponentially high range. The major challenge, unfortunately, is the accurate interpretation of the genetic variants. So as long as that big chunk of US is there, we still are not very confident. So we have to understand the impact of these genetic variants. We have to have large sources of genotypic as well as phenotypic data. So the more information, or what we now call it as HPO, human phenotype ontology, is very important. We should have a similar platform in how we describe the patient's phenotype, and this will help us in get better information. So a combination of better education in genetics as well as better tools for genetic decision support will be needed to integrate this genomic data. So clinical diagnosis, as always, will be the prime for all patients still. In spite of having such good diagnostic tools, the clinical examination head to toe, not missing out minor details, is still the first thing which is going to make a change. Thank you for that, and I'll hand over to Joseph. If you have any questions, please do let us know.
Okay, Dr. Sheetal, thank you very much for that very insightful talk on the role of NGS in diagnosing primary immunodeficiency. I now invite you all to type out your questions in the comments and Q&A chat window of the Zoom browser, and we will address them in a bit. In the meantime, we have received some initial questions from our audience during the registration process, and I'll now address them to Dr. Sheetal, who will answer those questions. So the first question is from Dr. Anureka from Chennai. How do you classify as pathogen, likely pathogenic, and variant of uncertain significance?
Dr. Anureka, I think already covered this in the slides, but just to summarize, as you can say, we classify them according to the guidelines of ACMG, that is American College of Medical Genetics. And pathogenic, likely pathogenic would be good variants in which we have literature evidence to support the thing that the variant which we have found is correlating with the disease phenotype. And variant of uncertain significance is a variant in which we do not have adequate literature, so we cannot classify them either as pathogenic nor as benign. So they remain in a pool till further evidence for that variant is available, so as to reclassify it after a period of probably 6 to 8 months.
So I know you covered most of the questions in the in your talk, but I just thought I'll just summarize some of these. So Dr. Archana from Pune is asking, what is the general percentage of VUS in NGS tests?
The percentage of VUS in NGS tests would again depend on how detailed the disorder has been worked up. So it will also be different for different disorders, different genes. But a general, if you want to see, almost 30 to 40% of the reports from labs would go out as variant of uncertain significance.
Dr. Tulsi from Chennai would like to know when should or what decides to ask for target gene sequencing or exome sequencing and whole genome sequencing. So when should we go for any of these options?
I think I have taken up this question also, but it would, as I told, would depend on your differential diagnosis. So clear your diagnosis with a good laboratory backup, biopsy, MRI, whatever. So higher your confidence in your differential diagnosis, you can choose a test. So if you're suspecting Wilson disease, you can directly go in for a single gene sequencing also. For other disorders in which there are multiple number of genes and based on the phenotype, obviously we won't be able to decipher which gene it is, let alone which variant it is, or if it is a very big gene in which doing a target sequencing is not cost effective, then we have either the exome sequencing or whole genome sequencing for diagnostic purpose. Still we won't recommend because definitely the cost would be very high, and secondly we would be getting a lot of data for which we don't have enough literature. So probably the number of uncertain significance variants, because we will be getting intronic and other variants for which we don't have much information yet. So for diagnostic purposes or a clinical purpose, you can choose from panels to clinical exome to whole exome sequencing.
Dr. Mahesh from Nipani wants to know, can we use NGS in undiagnosed PID?
Definitely, I think for undiagnosed PID itself, NGS would be quite beneficial based on the number of genes which we already know related to primary immunodeficiency. Undiagnosed, I'm not able to get whether it is undiagnosed or unknown. Undiagnosed, we would get depending on the gene list which we have. And if the gene itself is unknown, then probably we may have to go for higher studies. Any other question?
Yeah, so we got a couple of questions from the live audience. So what are the causes and treatment of CVID?
CVID is again a group of disorder in which immune system is obviously not made. So it is a group of primary immunodeficiency. Causes would be, usually it is sporadic, but there are familial conditions also. And there are a list, most common is TNFRSF13B gene, but that is only in 10% of the cases. It has been associated with almost 10 genes, but mostly there are unknown genes or unknown causes for CVID. And as I have described earlier, immunodeficiency disorder, the immunoglobulin replacement therapy is the main treatment option. But again, you will have to refer the child or to an immunologist who would decipher the final diagnosis and do the appropriate treatment. Immunosuppressive therapy or steroids may also have to be given sometimes. How to proceed?
How to proceed? Dr. Ramalingam would like to know how to proceed with variants that do not have any phenotypic changes.
So I think it goes. This would be for those where a VUS has been reported, right? So yes, this is a big group of disorders. Again, phenotype might not change, but the data which we have for particular genes might change. So if there is a non-report or a VUS report today, or like 2 years ago, if you have done and still there is no phenotypic change, then probably over a period of a year or so, there's lots of work being going on in each and every genetic disorder. So probably in a period of a year or so, if the phenotype doesn't change, then a new gene has come up or a variant which we had ignored previously because of reasons like not adequate literature or a high map. As the number of testing for those increase, the pickup rate of the gene might change. So even if the phenotype change is not there, the genotype may change based on the available literature after some time. So we can definitely proceed after wait and watch policy is what I do personally. So after 6 months, 8 months, we can go back to the lab and tell them that can you please reanalyze the data as we had not got anything in the past result. I hope I have answered your question.
Okay, so we don't have any more questions from the audience at the moment. So I'd like to thank Dr. Sheetal for taking time off and giving us this webinar, and I hope the audience was able to take away some useful information from this topic. And if you have any more questions or comments, or if you have some doubts that arise later, please don't hesitate to get in touch with us. So we can be reached at the toll-free number down below there at 1-800-103-3691, or you could write to us at diagnostics@medgenome.com, and I assure you somebody or the other will definitely get in touch with you and address your queries. And just a reminder that we will be sending out the recording of this webinar in a couple of days. And you can take it and you can view it in your own free time. And if you have any queries after that, also you can get in touch with us. And we'll be having more of these webinars in the future. We are lining up some topics, so we'll definitely send out mails and make sure everybody's aware of the webinar topics that we are having. And if you have any suggestions on webinars, also you could write into us any topics that you wanted to address, and we'll definitely try and address those topics for you. So that's about it for this time, and thank you again for your time taken, and have a nice day. Thank you.
Thank you all.